Chamber. Programme signed. This is the Northern Ireland Assembly Senate Chamber. Programme signed.
On the recording equipment. I have no apologies
This is the Northern Ireland
received.
Assembly
Do members
Senate.
have any apologies? Okay, members, under Chairperson's business, there is a letter here tabled today from the Minister in relation to the issue of emergency care. Interestingly, the Minister is talking about a process of review, which I think is important. He has asked RQIA to do two things to ensure that the Belfast Trust and the wider health and social care can act as effectively as possible, which is firstly carrying out inspections of the RVH site, and he secondly asked for an external expert team, which again I think is fairly significant and important. So I think as a committee we certainly should welcome the fact that there is a review called. I suggest and hope that this is the Minister listening to the very genuine concerns and in fact view that there is a crisis within our emergency care. And I think we should seek an update. The Minister does say in his letter that he'll provide us with the terms of reference. He's coming before the committee on the 12th of this month. So hopefully we will have more details, but I do think it's fairly significant, and we look forward to seeing the terms of reference and of course the impact it will have on other hospital settings. But just to make you aware, that is in the tabled papers today. The second item I have under Chairperson's business is myself and the Clerk met with Diabetes NI just before lunch today. They have raised a number of issues in relation to the motion that was passed in the Assembly in 2012. I'm suggesting, members, that we write to the Department to seek an update on, first of all, the status of the draft strategy and action plan, including a publication date. Secondly, an update on the work being done by the Public Health Agency on diabetes, including provision of self-management plans. It was a very specific issue that they raised. And also an update on what is available in terms of services for those with diabetes across the 5 trusts. And I'm suggesting also that the Diabetes NI have an event scheduled for the Long Gallery, and we can circulate the date of that, but I think it would be important. I know a number of Health Committee members are part of the all-party group that we supported that event. I'm also suggesting that in order to continue the communication with the committee, that we write to the organisation and invite them along to our event, our speed dating event as it's been called, on the 2nd of April. So if members are comfortable with that, we can proceed as outlined. The other issue I just want to make reference to is that Leanne is leaving the committee. After almost 4 years, I think, of work and going to the Justice Committee. So I have to say that always the winner, Jim, always the winner. So I want to formally thank Leanne for the work that you have played for those years with the committee, and thank you personally as well. You've been a great support to me as chair. And I want to welcome Ines, who will be replacing her. You're very welcome, and we look forward to working formally with you. And best of luck, Leanne, with your new endeavours. Also, I just want to remind members as well that the committee had agreed to attend the NICON conference on transforming your care on the 5th of March. So there are forms on the tables. I'm asking members to complete the forms and indicate their availability, just and return them to the clerk afterwards. Moving to item 3 is the draft minutes of the meeting on the 29th of January at page 8. Can I ask our members content with the minutes?
Great.
Okay, thank you. Item 4 is a review of waiting times. We have an evidence session with Dr. Rob Finlay. I want to refer members to the letter from the Minister on page 13, setting out his approach to the issue of waiting times. And the committee will be holding an evidence session with the Department and the HSE Board at a later date. In the meantime, I'm suggesting we write for clarification on the following issues that have come up through the Minister's letter. What work effectively has been undertaken or is being undertaken to look at what drives demand for elective care, and whether any work is being done with GPs on the issue of referrals would be one of the first issues. Also, we would seek a summary of the piece of work carried out by the Board in 2013 to assess the core capacity in each trust for each speciality. Again, it was something that was reflected in the Minister's response, and we would seek that should include detail of where the gaps in core provision exist across the trust and across the different specialities. Also, a breakdown of the amount of non-recurrent funding which has been allocated to the trust over the last 5 years to create that additional in-house capacity and to make use of the private sector, which is also referred to in the response. Information on whether the Board has withdrawn funding from any of the trusts for not to meet their core capacity targets, and whether the Department has costed a move to the referral to treatment measurement, which is the issue about the complete journey time, if you like, of which we're going to hear more in the presentation. So if members are comfortable that we seek clarification on those issues. Roy?
Great,
Yeah.
comfortable with that. One further issue in referring to the referral to treatment waiting times. The Minister's highlighted that there's disparate reporting systems currently used by the Health and Social Care Trust in Northern Ireland. I thought we were moving towards an integrated IT system, and you would want to ensure that any new system, any changes that are occurring will enable movement towards such an integrated system, so that this would be possible in the future. So can we seek reassurance that that is the case?
Yeah, I think you're absolutely right, and it's very clear that it talks about a disparity in reporting systems, and I think we need to get a sense of that when we're asking for the core capacity of each trust and to identify where the gaps are. So yes, I'd support that to take place as part of it. Okay, members, moving on, there's a briefing paper on page 16 and page 3 of the tabled papers. I want to welcome Dr. Rob Finlay. The normal procedure here is that we would ask you to give a 10-minute presentation, and then we would open up to questions and answers. So you're very welcome, and we do appreciate you taking the time to come before us today.
Thank you, Chairperson. It's a privilege to be here. I probably won't take up as long as 10 minutes of your time with my introduction, but I would like to talk a little bit about one of the issues that I've drawn attention to in my briefing note. And I'd like you to imagine for a moment that you are the manager in a hospital where you have a lot of long-waiting patients on your waiting list. Now, what you would like to do is you'd like to do the right thing for your long-waiting patients and treat them. Now imagine that you've got the capacity laid on, you're treating your long-waiting patients. What happens to the proportion of the patients you treat who are long waiters? Well, if you're treating your long waiters, then for a while the proportion of long waiters you are treating goes up because you're treating lots of long waiters. The number of long waiters left on your waiting list goes down. So we've done the right thing, we've treated our long waiters, and the number of long waiters left on the waiting list has gone down. Very simple stuff. What I want to explain now is how the English NHS got on the wrong side of that very simple concept and ended up in some difficulty with their waiting time targets. I think you have a copy of a piece of paper that looks something like that.
Yeah, it's in the table. It's in the table papers.
Yep.
Yeah.
This is an extract from the Guardian website, and it says waiting lists grew 61% in the past year. And at the bottom of the page, I've put the statistics that this story came from. And you'll see that of the patients that the number of patients admitted during the month who had waited 26 plus weeks rose from 7,360 in June 2010 to 11,857 in June 2011. And those of you who are good at your 61 times tables will know that that's 61.1% increase. So what does that 61% mean? Does it mean that the waiting list got bigger by 61%? No, it doesn't. Does it even mean that the number of long waiters got bigger by 61%? No, it doesn't. It means that the number of long waiters being treated went up by 61%. If you treat more long waiters, then there are fewer long waiters left on the waiting list, you would expect, and that is indeed what you find. If you look at the second row of numbers, the number of patients still waiting, who have waited over 26 weeks, fell from 95,814 to 93,123, a decrease of 2.8%. So, waiting list grew 61% in the past year. Sounds terrible. But that's not what happened. They treated their long waiters. The number of long waiters still remaining on the waiting list went down. Long waiters got their operations. It's a good thing that happened. And interestingly, if you challenge newspapers who print reports like this, as I did, their response is almost invariably the same. These are the figures the government put out. We are reporting the figures the government put out. And so the word of caution I'd put to you is that if you in Northern Ireland were to implement targets in the same way that the English did, and then follow those figures, you may end up with headlines like this, even when actually things have got better, not worse. Just to go a little bit deeper into the story, you have a chart from University College London hospitals. There are two charts. I should say at the outset that I do not in any way blame the hospital for what they did, for what I'm going to explain to you that happened here, because this was during the era of targets and terror. If you were an English hospital and you were failing against the targets, the consequences were very severe, both financially and in terms of your personal career. What the top chart shows is the performance of this hospital trust against the headline target in England, which was that 90% of the patients being admitted, i.e. treated as an inpatient and day case, 90% of the patients being admitted should have waited less than 18 weeks. Over on the left, in 2008, you can see the target being achieved for the first time as the line drops below 18 weeks. And the hospital successfully achieved the target every single month thereafter. They kept their nose so clean that if we look in 2011, I've put a couple of markers on the timeline there. The first marker is that this particular hospital, UCLH, did not appear in a list of 28 hospitals who were failing on the long waits target. And a few months later, the Prime Minister, David Cameron, honoured them with his presence so that he could give a speech at which he pledged not to lose control of waiting times. If you look at the bottom chart, though, you will see what was happening underneath those figures on the waiting list itself. The dotted line shows how long 92% of the patients on the list were waiting up to, and you can see that it was going up to, well, not far off a year at the time in 2011. And the solid line, which is plotted on the right-hand scale, shows how many one-year waiters there were on the waiting list, who'd waited more than a year since referral. And you can see that that peaked at somewhere around 1,700 one-year waiters just at one hospital trust, just before the Prime Minister came down to give his speech. So on the one hand, according to the headline target, we have a very rosy picture of short waits. But on the other hand, if you actually look at the waiting list, you can see that there were patients waiting very, very long amounts of time indeed. So if you want the true picture of what's happening on waiting times, always look at the waiting list. Don't simply rely on looking at the waiting times of those patients lucky enough to get treatment. The final chart I'd like to draw your attention to looks like this. Excellent. And these are England overall figures for a similar period. And what happened just after the latest figures were released, in I think it was about June 2011, the Deputy Chief Executive of the NHS in England wrote a very fierce letter around all of the chief executives of every NHS organisation, in which he said, "It is unacceptable for performance to fall below the expected standards, as it did in February and March 2011. Now, if you look at that chart, in which months did the NHS fall below an acceptable standard in England? If you look at the dotted line, you can see that, which shows what the position was like on the waiting list. You can see that 90% of the waiting list was waiting up to, well, 19 and a bit weeks at the peak there, around about January 2011. That's when there were a lot of long waiters on the waiting list. In February and March, which are the months that the Deputy Chief Executive drew attention to, February and March was when the NHS treated its long waiting patients and sorted the problem out. So what he was criticising was actually the NHS fixing the problem, not the months when the NHS had the problem in England. Now, I've devoted my few minutes to this particular point because it's something that's got the NHS in England in some difficulty in the past. It's an apparently technical and arcane distinction, perhaps, between the waiting times of the patients being treated and the waiting times of the patients still on the list. You might think that the one would be a reflection of the other. What I've hoped to explain to you is that they are not necessarily a reflection of each other, and it's worse than that. If you actually apply a target to the waiting times of those patients being treated, it distorts the behaviour of managers. All targets distort behaviour, that's their purpose, but it distorts their behaviour in particular ways that are unhelpful. And with that, I will conclude, and I look forward to your questions.
Okay, thank you, Dr. Finlay, for that very useful overview. I suppose, first of all, to say that this is something the committee take very seriously, for very obvious reasons in relation to delivery of health. And one of the lessons, I suppose, as we are researching this and taking different evidence sessions and talking to the department and other experts in the field, if you like, is that it is the complete journey time that needs to be examined. Also a sense, particularly coming out of the professor from Trinity College, that to throw money or finances at one part of this particular issue may not, in his interpretation, resolve it, and can often be seen as, and I welcome your views on this, as actually rewarding bad practice in some ways. But specifically in relation to the RTT system that you talked to, we have a response from the Minister in front of us today, and he's stating that that will be both challenging, both financially and logistically. And he's referring to the disparate reporting systems that exist across the Trust. And I'm very interested in how credible you think that is as preventing us, I suppose, in some sense of looking at the whole patient journey. So I'm just interested in your view on that.
Yes, thank you, Chairperson. Yes, I mean, measuring the journey time from referral all the way through to treatment has obvious benefits over measuring each stage of treatment separately. The principal benefit being that a typical surgical patient may take the following route through the system. Imagine that you go to your general practitioner with a sore knee. Your GP may look at your knee and say, I don't like the look of that, I'd like you to go and see a consultant, please. So you are referred to the hospital. At that point, the clock starts. You may then have a wait, and then you see the consultant for your first outpatient appointment. On a stage of treatment basis, your clock would then stop. On an RTT referral to treatment basis, your clock carries on ticking, because what happens next is the crucial thing that referral to treatment RTT targets capture, that stage of treatment targets don't capture, which is that the consultant may say, I don't like the look of your knee either, but I would like you to have a scan to check. So you go off and have a diagnostic. You then need to see the consultant again after the scan has been done, so that the consultant can make a definitive decision about whether or not you need surgery. And you may need a further test and then come back again after that. Now, this cycle of diagnostic and follow-up outpatient appointment can take a lot of time. And there's a possible perverse incentive as well, which I'll come back to in a moment. After the decision has been made to offer you surgery, you then have the wait for inpatient treatment, which under a stage of treatment target regime would be captured as a waiting time in its own right, and then you get your operation. Now, the perverse incentive, the potential perverse incentive is this. Imagine that you are a manager in a hospital again, and you have a very large waiting list for surgery, and you can't keep up with the demand for surgery. You want to try to slow the number of patients who are arriving on your inpatient waiting list. There is the potential, I'm not saying that it's actually happening in Northern Ireland, I don't know, I haven't seen the data, but there is the potential to delay patients at this diagnostic and follow-up outpatient stage, where they are not tracked by a stage of treatment target. So that's a potential difficulty with stage of treatment. RTT, the clock carries ticking all the way up to the point where they actually get their definitive treatment. So there's a clear advantage for RTT. However, it is correct to say that RTT is more difficult to measure. There are two main kinds of RTT target. One is the kind that measures how long the patient waited, but it only captures that measurement at the point where the patient gets treated. Now, as I've just explained to you, that can get you in hot water if that's what you monitor. So the better thing to do is to measure referral to treatment waiting times while the patient is still waiting, while the patient is on the waiting list. That's more difficult. You see, if you're measuring RTT waiting times at the point where the patient's treated, all you have to do is say, right, you've been treated, so let's look back. When was your referral date? Your referral date was back then, so you have waited this long. That's the figure you report as the waiting time. If you're trying to capture all the patients who are still waiting, you have to measure their waiting time since referral at every stage in their journey, when they're waiting for outpatients, when they're waiting for diagnostics, when they're waiting for a follow-up outpatient, and when they're waiting for surgery. Now, that might be 2, 3, 4, 5 different IT systems. It may include some paper-based waiting list management systems in the hospital. The data for every one of those. That's a big challenge. That's a big challenge. So if you propose to implement referral to treatment waiting time targets, which I think would be a good idea, you should be advised that it is likely to take some years before you can implement them with good coverage in practice, and that during the transition period it would be a good idea to retain the stage of treatment waiting time monitoring and targeting as well while the new system phases in. But both systems should be based on the patient still waiting and not focusing primarily on the waiting times of patients as they come in, as previously explained. You raised one further point, Chairperson, which was about rewarding failure, throwing money at the places where there are problems and it not resolving the problem. I think there are ways around that. That question falls into several parts. The issue about rewarding failure, the key to this point is to understand that waiting times are a function of two things. Firstly, how long is the queue? And secondly, in what order are the patients being treated? So if you think of your everyday experience, if you go to a supermarket, it matters that the queuing system is fair, so that you have a free choice of which queue to join. You can estimate, that you'll get to the front. Or if you go into the post office where you have a single queue, everybody gets seen on a first-come, first-served basis. That's a fair queue. If you have a lot of queue jumpers pushing in ahead of you, then you will wait longer. So queue jumping pushes waiting times up and can be unfair. In hospitals, You have patients with urgent clinical conditions such as cancer or aneurysms that need repair. You have a number of patients whose clinical need is greater than the clinical needs of others. Those patients absolutely must be treated ahead of the others, and they need to get their treatment quickly enough for their clinical condition. And while we're talking about waiting times, that, incidentally, is the single most important thing that any hospital can do, is to make sure that its urgent patients are always treated quickly.
Okay.
Now, they're jumping the queue. That pushes up the waiting times for others, but that's okay, because that's a good reason to jump the queue. So, to the extent that the long waiting times are caused by inappropriate waiting list management, which is mostly pulling patients out of order when there's no good reason to, you don't want to be rewarding that kind of behaviour by throwing money at it. But that's easy enough to detect. If the problem, on the other hand, is caused by the waiting list being too big, well, then I think there's a fair argument that money is the appropriate solution to that, because the hospital has a queue that's very big, and the way to get rid of a big queue is to treat the patients. There would then be the argument, oh, well, we throw money at a long queue, but it draws in demand and the queue never goes away. If you did that, if you had a hospital in isolation, and you eliminated the queues at that hospital, yes, I agree, it could draw in demand from the surrounding areas, and you would apparently have achieved nothing at that hospital. But I think if you did it across the whole of Northern Ireland, I don't think you would necessarily see that. The experience from England is that when the referral to treatment waiting time targets were achieved in England, GP referrals did step up, and they stepped up significantly. I estimate it at about 22%. But that isn't a tsunami of demand. That isn't losing control of demand. It's not opening the floodgates. It's 22%. So bringing down waiting times, yes, it may increase demand. Some of that demand may have arisen anyway. But I think it's a counsel of despair to say there's no point in trying to shorten waiting times because we'll only end up back where we started. I don't personally think the evidence supports that.
Okay. I mean, I think it's extremely useful, that advice about looking at the waiting list as opposed to the patient waiting time. I think that's really important. And you probably have answered my question around what you would view would be the reluctance within the health service to look at RTT. You're explaining that it is complex and a difficult process, but are you aware of maybe other regions maybe that have moved to RTT and maybe an indication of cost? Because one of the challenges that we're being told is financial constraints.
I can't answer the question about cost, I'm afraid. England is quite a long way down the road with this. They started with RTT, I think it was 2004 from memory that they announced it, and the target was first met in 2008. Initially measuring it only on the basis of the retrospective wait when the patient got treated, but now also capturing all the patients who are still waiting. Even in England, where they've been doing it for some years, they're still not capturing the whole waiting list. If you look at the data by specialty, by hospital, you still see hospitals discovering waiting lists that they hadn't previously been reporting, and you get a step up in the number waiting. That still happens. Scotland has been doing it for a few years less. If you wanted to seek evidence on this, I think Scotland would be a good place for you to seek a witness. I understand you have somebody from Scotland coming here next week, and they may be able to help you find an information analyst who is very close to the issues, who may be willing to assist you.
Yeah, we have looked at the Scottish model through the assembly research processes here. Well, that's very useful, but a number of people here want to speak. Of Roy first.
You mentioned that someone attempted to produce better figures by moving on to other waiting lists, etc., or massaging the figures. It would be easy to detect. How would it be easy to detect?
It is possible. Well, our company has done quite a lot of research in this area to understand the dynamics of waiting times management, looking at the arrival rate of patients on the waiting list. how you can book patients in so that urgent patients are always, well, it's following the 3 principles in my paragraph 1, safe, fair, short, and I would add one more to that, and that's efficient. So the principles are that urgent patients must always be treated within their clinically safe limit. Fair means that routine patients should, broadly speaking, be treated on a first-come, first-served basis. And I say broadly because there are always going to be exceptions. Short means that no patient should wait an unreasonably long amount of time, and efficient means that the hospital should be able to fully utilise its capacity in doing all of this. We've established some very simple rules that hospitals can follow on a patient-by-patient basis, which will always keep the waiting list continuously optimised in that way. And by studying that in simulation, we've got the link established between the size of the waiting list and the times that patients wait. So we can tell you, if you were to give me figures that said patients are arriving on the waiting list at a given rate, this is the number of patients on the waiting list, this is the proportion that are urgent, this is the proportion who are removed without being treated, and this hospital is managing the list on either a fully or a partially booked basis, I would then be able to tell you, in that case, you would expect 90%, or whatever you want to know, 90% of the patients on the waiting list would be waiting less than X weeks, if the list was managed according to those rules. Now, in practice, hospitals tend not to manage it in that optimal way, so you'd allow a little bit of a tolerance, but anything much beyond that, and it's, well, there is scope for improving the waiting times simply by managing patients in a better order. And we can do this visually as well. This is going to look slightly odd in the Hansard record, but a normal waiting list looks a bit like an elephant. So you have the head dropping at the start where the urgent patients are coming in, then the elephant has a flat back where no patients are coming in because they're waiting their turn, and then the elephant's rear drops off very steeply at the back where the patients are coming in, broadly on a first-come, first-served basis. If you look at a real NHS waiting list, it tends to look like a dinosaur's tail. So you have quite a lot of patients at the front, and then you have the waiting list dribbling on and on and on and on up to, 20, 30, 40 weeks. And you quite often, it is not at all uncommon to see on that waiting list urgent patients who have waited much longer than they should have waited, to find that there are long waiting patients who do not even have an appointment for surgery, while at the same time very short waiting patients who've only arrived on the list 2 or 3 weeks ago have already got dates for their operations in the next week or two. That is very, very common. So it is quite easy to detect when a waiting list is being managed not according to those well-accepted principles, and to work out what it would look like if it was, and therefore whether a backlog clearance is needed to bring waiting times down to a target level.
You mentioned some people can be on the list for a long period. In my constituents' work, I've come across constituents who have perhaps waited 6 months for exploratory surgery with one particular consultant, and then who have been advised that, sorry, it's not this problem, it's actually a different problem. And the 6 months clock, they've been told, starts again with a second consultant. What is the case elsewhere? How would that, because it seemed to wait for a year or before you will see the appropriate consultant would seem to be an excessive, and it may be even more than that, to see the appropriate consultant does seem to be excessive. What would be the case in England and Scotland?
Without knowing the full specifics of the case, this sounds a little bit like a stage of treatment issue as opposed to a referral to treatment issue. So your constituent has waited a certain amount of time to see one consultant. At the moment they walked in the door to see the consultant, the clock stopped. Then if they are then referred to another consultant, a new clock has started for that second wait. Now, in England and I think also in Scotland, but I'm not 100% sure about Scotland, but certainly in England, if they were waiting to see the second consultant and it was for the same condition, the original clock would be still ticking. So the measurement against the 18-week target, the clock would still be ticking all the way through that. This is a cause of some anxiety for tertiary hospitals in England. If you have a great big teaching hospital with super specialists, they quite often have patients referred to them who've already got 16 weeks on the clock, and it's difficult, very, very difficult for them to treat that patient within 18 weeks. So it's a cause of some anxiety for them.
Okay, thank you.
Thank you. Jim, indicated.
It's a bit uncanny. My daughter, to speak, 5 minutes ago was wheeled into an operating theatre for a knee surgery, and she waited for over a year for that. Now, the reality is it was a result of a skiing accident, and whilst it was inconvenient and slightly painful, the reality is that had the operation occurred in another year's time, probably there would be really no difference in the outcome. So has there been any empirical work done to establish, do delays lead to worse outcomes, or is it just inconvenience to the patient? Has there been any work to show the longer you wait for these type of routine procedures, the worse the outcome maybe 5 years down the line?
This is a little bit outside my field of expertise, and I'm not sure I can give you a definitive answer on this, but I think that you would probably find that there are some cases where it would matter and there are some cases where it wouldn't matter. If some conditions deteriorate, sometimes the operation might save your life, particularly if it was an aggressive cancer or an aortic aneurysm or heart surgery or something like that. But as I say, we're a bit outside my field of expertise here.
But am I right in thinking the vast majority of these are things like hips and knees, and I can think of dozens of constituents who have contacted me complaining about the 17-week wait, even to be put on the list for a knee replacement. But at the end of the day, it's very painful, but it's not fatal. Is that not the norm when we're talking about waiting lists? Is that type of thing? Or are we dealing with a lot more complicated issues than that, if it's not urgent?
I think your question perhaps is more of a rationing question than a waiting question. My view on that would be that if the patient and their doctor have agreed that the patient should have an operation, and if the NHS has promised the operation, my view would be that the NHS should deliver on its promise. If the NHS does not intend to operate on a patient because it considers the condition to be, it considers the treatment to be of low clinical value, then that should be clear to the patient at the outset. This is something that has been done in England, particularly for things like tonsillectomies and varicose veins, I think from memory, where there are procedures of low clinical effectiveness and fewer patients are being offered surgery for it. You may be right that some patients may not come to harm or come to very limited harm by waiting a very long amount of time. I think my view simply is that the NHS has made a promise and it should deliver.
Within the various trusts in GB, have any of them reached the stage where they've been come close to eliminating or dramatically reducing, and can that be done without throwing vast amounts of money at the problem?
To eliminating the waiting list?
To get in down to sort of a month or something ridiculous like that, something very, very short. Is anybody coming close to that target?
Yes, there are particular areas. It's a very curious thing about waiting lists, that you have some areas with very large pressures and some areas with very little. And, this brings us into the whole area of planning. The NHS is relatively good at big set-piece plans, so planning for next financial year, doing a business case for a consultant or capital development, this sort of big adjustments to capacity. If you were the captain of a ship, this would be charting your course. My impression is that what happens a bit less well is the constant adjustments on the tiller that keep you on that course. The continually adjusting capacity to keep up with demand. That's something that the NHS is not quite so good at. Planning on a time horizon of 6 weeks to a few months into the future. And so what happens is that the capacity that the NHS is laying on drifts out of line with the demand for healthcare. So you end up with some areas with very big waiting lists and very long waiting times, and you end up with other areas where people can go home in the middle of the afternoon because there aren't that many patients to treat. Now, this is an issue about planning, about evening out the pressures, and about the internal allocation of existing resource to the areas where it's most needed, so as to relieve the pressures on the hardest pressed areas by recycling resource from the areas under less pressure. And there are areas that are under less pressure, and there is scope to do that. It isn't currently done as well as it could be, certainly in my experience in England and Scotland.
So you're saying that with proper planning, you can greatly reduce the waiting list without throwing vast amounts of extra funding?
You can even out the pressures between different services. Planning should be done ideally at the level of inflexibility in the system. So let's take orthopaedics, for instance. Now, you have consultant orthopaedic surgeons, but they're mostly subspecialised now. So you will have some that do hips and knees, or possibly only hips, or in a very, very big hospital, you might have surgeons who only do hip revisions. Then you'll have shoulder surgeons, spinal surgeons, hand surgeons, foot and ankle. Well, to the extent that they only do the one particular kind of procedure, that's the level of inflexibility. Now, what you quite often find in England is that spinal surgery, in orthopaedics, spinal surgery is where the pressures tend to be. If you've got a big teaching hospital and you look at the orthopaedic waiting list, those patients waiting out to a year are very often spinal patients. It's difficult for the hospital to find the capacity in the system to treat them all. Some of the operations, they can be 14 hours on the operating table. So there's a particular subspecialty where over a long period of time, the planning has not made sure that capacity is aligned with demand. And at the same time, you may have hand surgery, which in some hospitals, but not all, you may have quite short waiting times for.
And are there any particularly good examples of trusts in the mainland that have cracked this? Because obviously this is a big political issue in Northern Ireland. It's probably the big headline. It's the waiting time at A&Es and it's waiting time for routine operations. And to some extent, the efficiency of a health trust is actually measured by those two figures. Yeah. In my opinion, to some extent, at the expense of perhaps quality of care, we have to get these figures down. Now, are there examples in GB where proper planning, rather than huge amounts of additional money, have produced these type of results?
Not that I'm aware of, actually. I think it's a problem almost everywhere. If you have, what tends to happen is that you get waiting list initiatives are very, very often done. So you have not an early warning of pressure. You have actual pressure. You have actual long waiters. Hospitals have difficulty booking patients in within a reasonable amount of time, so they know that they're going to have trouble with their waiting times. So they lay on a waiting list initiative, they negotiate extra capacity, they put non-recurring money into it, and they clear the problem for the month. And then guess what? A couple of months later, they got the problem again. And they got the problem again because it isn't an issue that there's a backlog that needs clearing. The issue is that supply is not keeping up with demand. It's their baseline that's wrong. They don't need extra now just to clear a bit of list. The problem is that their list is growing. They're not keeping up. And it is amazing, even now, you will find examples in English hospitals where the plans for next year are not based on demand. They're based on the hospital's ability to supply. Let me give you a more sophisticated example of that. Sometimes, if you have a hospital that's doing its plans for next year, and it's a very inclusive process involving all the stakeholders, all the general managers within the hospital and the clinicians, and they say so it's a very devolved process, and you say to the managers, what's your plan for next year? And they might go through a sum that goes something like this. Well, I've got this many consultants, they've got this many sessions a week, and they do this many patients a session. So if you multiply those three numbers, that's the number of patients we can treat every week. Multiply that by 42 weeks of the year, or however many weeks the consultants work, and that's the number of patients we're going to treat in the year, and that's our plan. So where is the demand for healthcare in that calculation? Nowhere. It's a plan that's purely based on the hospital's ability to deliver. Now, I know that in Northern Ireland you have an exercise which is about planning capacity starting from demand, and that's the right thing to do. I have to say, in England, that does happen. It happens possibly even in most places, but it's by no means universal, and there are a significant number of hospitals in England who base their plans on their capacity to deliver and not starting from the demand for healthcare.
I was hoping you were going to point us in the direction of South Essex or North Yorkshire somewhere,
Sorry.
which is the example we could all go over and get the information and come back and solve our problem.
There are lots of hospitals that do the big long-range planning based on demand. probably most of them. There are lots of hospitals that tweak their capacity at short range, the next 2, 3, 4, 5 weeks, to respond to specific problems. But the crucial range, 6 weeks to a few months, which is outside the annual leave notice period, when you don't know the names of most of the patients, when the capacity is still reasonably flexible, good week-by-week planning in that area. I don't know of any examples of hospitals that are really good at that.
Now, we had a brief chat about this over lunch, and it's a point that I made when Professor Norman was here recently. It never ceases to amaze me when they build a new primary school in South Down, children just appear from nowhere. It's extraordinary because you add the sum of the total of all the old schools that are replaced, and suddenly there's another 50 children, and we don't know where they came from. Similarly, if you build a new road, the traffic will increase to populate that road very quickly, and suddenly you've got as much of a problem with tailbacks as ever. Is there evidence out there that there's a latent demand that isn't in the stats, which will become evident if a trust is performing particularly well? In other words, will people who their GPs read themselves, and there's no sense putting my name down for that routine operation because, frankly, going to have to wait ages to do it? Does it become a sort of self-perpetuating problem in that more people come forward because the rumours got out that you get quick treatment?
I think you need to ask a health economist, but I will make 2 observations. Firstly, as I understand it, it's quite well known that that you do stimulate demand if you appoint a new consultant, particularly if it's a consultant that has a special interest that isn't currently served in the local population. You get people popping up who've got that particular condition wanting treatment. My other observation is that you build a new motorway and it quickly fills up with cars. Hey, at least people are getting to their destinations quicker. So it isn't necessarily a bad thing.
Yeah, but the demand on the services is still as intense. If new people are coming forward to replace the more efficient model that you have, you don't actually ever get to the bottom of the pile, as it were, because people are even maybe coming into the area for the treatment because the rumour has got out that there's a particularly efficient model.
Yes, I mean, I go back to the remarks I made earlier about the experience in England. When, in 2007, there were hundreds of thousands of patients on the waiting list who'd waited over a year. 92nd centile waiting times were out to nearly a year. Now, there are only a few hundred patients on the waiting list over a year in England, and 92% of the waiting list is well within 18 weeks. So there's been an enormous reduction in waiting times in England across the whole country. And yes, there has been a step up in GP referrals in that period, 22%, as I mentioned earlier. But it's not out of control. It rose, and then it broadly stopped rising. It was a step. So, as I say, I think a health economist would be a better person to ask, but I'm not convinced that there is good evidence of the rationing impact of waiting times.
Thank you.
Just very briefly.
Okay, go ahead, yeah.
Just talk about hospital need to react to demand rather than their plan. And there's a particular question there is there good examples elsewhere where hospitals do quickly adapt to that demand? My perception has been that generally what happens is that normally end of year monitoring, there's money comes and then it's just fired off to the private sector for them to go and deal with it, rather than the hospital's consultants putting in additional capacity themselves and perhaps overtime for staff. So have you good examples elsewhere?
I recognise that scenario from England and Scotland as well, particularly England, where the use of the private sector is more widespread. Yes, I think, well, certainly in England, most hospitals could do a better job of planning their baseline capacity in line with demand over all timescales, but particularly the key 6 weeks to a few months into the future timescale, which is when they need to be responding to seasonality and changes. The use of the private sector is quite widespread in England. It's not necessarily an easy option for the hospital. They are losing the income by paying for the treatment in the private sector. It may cost more or less, depending on the deal they've struck. I don't have a particular view on the public or private merits, but I would make one observation about the potential conflict of interest that it puts in front of the consultant. If it's the same consultant operating on the patient in the private sector, as would have operated on the patient in the public sector, and the consultant's being paid for that, then there is a potential conflict of interest for that consultant that could push them in the direction of maintaining long waiting times. How do you solve that if you are using the private sector and it's the same consultants? Well, I mean, one option would be to try to make sure it's not the same consultant. It can be difficult to persuade patients to change consultants if they've already met them in clinic. I would like to see the nice doctor I saw in clinic, please, is what most, not all, but most patients would typically say. So the time to move them ideally would be before the first outpatient appointment. You'll get many more patients will agree to move at that stage than after outpatients.
Okay, thank you.
Just to have one point, but now two, because of just for the point that Roy was making. Does therefore the use of the private sector, in terms of getting rid of the problem quickly, does that encourage bad practice?
What sort
overall
of bad practice do you
in terms of actually meaningfully dealing with the problem? Because what you're doing is you're dealing with something that's erupted in terms of, or you're factoring in something that will try and eradicate it, whereas you're not dealing with the problem as a whole.
Yes, I see what you mean. I suppose it could. But really, I think it's just another manifestation of not dealing with the underlying problem. And as I mentioned earlier, a waiting time problem falls into two parts. It may be that the waiting list is too big, or it may be that patients are being managed in the wrong order, or it may be both. In many hospitals, they don't know which of those two things is the problem. And the analysis exists now to tell the difference. But I think relying on short-term solutions, whether it's bringing in locum and bank staff, whether it's exporting patients to the private sector, whether it's some other short-term waiting list initiative, I think those are all part of the same approach of trying to fix a particular problem that we've got this week or this month, rather than realigning baseline capacity to fix the longer-term shortfall of capacity against demand, which incidentally is usually cheaper. It's usually cheaper for the NHS to adjust its baseline capacity than it is to pay usually premium rates for locum or other short-term work.
Yes, thank you for that. That's very helpful. The other point, I was struck by your original slide, and I was thinking of lies, damn lies, and statistics. Because in essence that was an interpretation by the paper of what you point to as otherwise good work, because there was a 2.8% drop in the overall figure. Jim was not able to drive you to a particular place in terms of expertise or an example of good practice. But could you reflect on what are the drivers for change, political, management, etc., and then and the particular ingredients then for change, if you could sum up for me?
Yes. My favourite Aesop's fable is the one about the sun and the wind trying to get the fellow's overcoat off. Yeah. So the wind blows and blows, and the harder the wind blows, the tighter the guy holds his coat around himself. And then the sun comes out and he goes, "Oh, that's lovely," and he takes his coat off. If you want something done, people have to want to do it. How do you make them want to do it? Now, in England, they did targets and terror. It achieved the result. There's no denying it. When the coalition government came in, they experimented with not having centrally enforced targets, and they were promptly rewarded with the failure that I showed in my third chart. And if they did the same, I'm sure they would be rewarded in the same way with another failure. The targets and terror approach worked. I have to say I'm not a great fan of targets per se. There's a risk that the target can be literally something you try to hit as accurately as possible, whereas really it should be a backstop, a minimum standard, something that the NHS usually comfortably exceeds, so that it's rare and unnecessary to enforce it. How could you reach that happy state of affairs? Well, if you were to have a target as a minimum standard, then you may wish to set it not as a stretch goal for the service to get to, but as something that the service should comfortably be able to achieve, and then to focus on getting well below that target by concentrating on the two underlying factors of waiting times, the size of the waiting list and the order in which patients are treated. Put very bluntly, as I've said in my paragraph 12, when focusing on waiting times, it's very easy to forget the waiting list. And this is something that happened very widespread across England. People forgot to watch the waiting list. If the waiting list is getting bigger, you have a problem. If the waiting list is going away, your problem is going away. And that, if you want to reach the happy position where there is no involuntary waiting in the NHS, getting rid of the waiting list is the way to do it.
Sorry, I'll just come back then. And you're saying about people having to want to do it, and target and terror worked. Not necessarily nice, but is that, in our context, then what would be the driver? Is it a ministerial will? Is it a departmental will? Is it at what point in the chain of command is the driver?
I'm afraid I can't give you. I mean, this is not my field of expertise. I'm not a manager or a politician. I think you'd better ask some other people about that one.
Okay, all right, thank you.
Okay, well, thank you for that. It's been very informative, Dr. Finlay, and thank you for taking the time. I think probably the lesson in this is, and I'm even reflecting on what we've called the review, we'd actually called the review waiting times, and even one of the pieces of learning coming out of this today is the waiting list, and not to lose sight of that. I think there's a recognition from your evidence that this is complex, but that processes like RTT are productive, can deliver if they're done alongside of your stage to patient journey as well. So all of that has been very useful. I think it's specifically relevant to us as well, a discussion around targets, and even just reflecting on your paper, you talked about even if there is a target, that it shouldn't be a 100% target.
Yes.
That you set your target and be realistic in terms of people and obstacles and changes and patient journey and cancellations and holidays or whatever it might be. So
Yes.
I think that's useful. So we really appreciate that
Thank you very
evidence.
much.
We are actively seeking and working our way through this process. I think it would be very useful if we could share the recommendations that we found with yourself and have your feedback
I'd be delighted to do that.
on that as well. Well, thank you very much
Great.
for sharing that with us
Thank you,
today.
everybody.
Thank you. Members, I'm asking if you're comfortable, can we adjourn just for a few minutes before we move to the next session? Okay, thank you. proposed hygiene rating bill with the Food Standards Agency. I'm referring members to the briefing on page 18 from the Food Standards Agency. I want to welcome Catherine Baker from Food Standards Agency and Maria Jennings from Food Standards Agency. The process, folks, is a 10-minute presentation, and we'll open it up to comments from members. So you're very welcome.
Thank you very much, Chair. Thank you all for giving us the opportunity to update the committee this afternoon on the Food Standards Agency's plans to introduce legislation to make it compulsory for food businesses to display their food hygiene rating, so that all consumers in Northern Ireland have the ability to make informed choices about where they eat. As you'll all know, the Food Standards Agency is a UK-wide government department, and in Northern Ireland it is accountable to the Assembly through the Health Minister. As food is a devolved matter where the FSA has the policy lead, legislation is made through DHSSPS. And you will recall that we appeared before the committee in 2013 regarding the food hygiene rating scheme to inform members that about the rationale behind the scheme, and that we would be seeking to put legislation in place to place it on a statutory footing. At present, the scheme operates in Northern Ireland on a voluntary basis. It's administered by District Council Environmental Health Officers, and food businesses are provided with information on the standards that they attain at each routine inspection. And whenever they're given that information, it is a numerical rating from 0 to 5. 5 being the highest rating, which means that the business at the time of inspection fully complies with the legal requirements. The rating is provided as a sticker which can be put up on the window or the door of the food business, but currently there's no legal requirement for the businesses to do this. And over the time that the food hygiene rating scheme has been running, we have been gathering evidence on how many businesses are currently displaying their ratings. We know that only about 50% of businesses actually choose to display their rating, and this drops to only 13% when we're talking about the businesses with the lowest ratings from 0 to 2. And since we last appeared before the committee, we've completed a public consultation exercise on our proposals for a statutory scheme. And in doing so, we sought to reinforce the framework on which the voluntary scheme is built, because that has been developed collaboratively with the enforcement community, with the food industry, and also with consumers. So we were very keen to build on that. And we carried out a number of traditional stakeholder events around the consultation. We went out and had lots of one-to-one meetings to discuss our proposals. We also gathered information directly from consumers, but importantly for the committee, we carried out face-to-face interviews with small and micro businesses, because we know that traditionally these groups wouldn't tend to get involved in formal consultation processes. So in addition to all of that, then we also received 29 responses on the consultation for a mix of from the enforcement community, from the industry, and also from consumers. We published that report in July, and since then we have been carrying out more consultation to make sure that we get the final policy position right. And in December of last year, the Executive agreed on our final policy position and to the drafting of the Food Hygiene Rating Bill, which you will get to see in due course. So just this afternoon, we would like to take the opportunity for a couple of minutes to provide a brief overview on some of the issues that were raised in the consultation, because people have different views on this issue. So I'll ask my colleague Catherine to outline some of the issues raised in the consultation.
Okay, thank you for inviting us here today. As Maria has already outlined, in producing our consultation proposals for a statutory scheme here, we were endeavouring to stick as much as possible to the voluntary scheme. This has been developed in consultation with all parties, with a lot of compromise and agreement. Obviously, one of the main differences in moving from a voluntary to a statutory scheme, however, is that food businesses would have to display their rating in a prominent location at their establishment. In response to the consultation around this issue, both consumers and District Council stakeholders expressed a very strong support for mandatory display, and views from food industry were mixed. Perhaps not surprising, Maria mentioned the Citizens Forum research we did with the small businesses. Those that had a high rating and were confident in the scheme were actually in favour of mandatory display. On the other hand, those with lower ratings were critical of the proposals. We do accept there is some opposition from the food industry, but we do believe that mandatory display will maximise the potential of the scheme. It will allow consumers to make informed decisions, and in turn this will provide a strong incentive for the businesses to comply with their existing legal requirements. During the consultation, we also posed the question, should councils deliver a statutory scheme by being required to do so, or voluntarily, as they currently do? And in response to this, a majority of respondents felt that councils should be compelled to operate a statutory scheme. They felt the voluntary approach carried the risks that councils could choose to opt out over time. And this could obviously result in a lot of inconsistency, both for the consumer, where they may or may not see information, but particularly for the businesses, where some businesses would be required to display their rating and others wouldn't. And this could be very pronounced at local authority boundaries, where businesses could be located geographically very close together. The scheme has been operating for 2 years, as Maria said, and there are safeguards built into the scheme for businesses. They include both a right to appeal the rating. So a business gets a rating and they dispute it, they can appeal this to their district council, and they also have a right to request for a re-inspection so their rating can be reassessed where they have made the necessary improvements. And this is to ensure that businesses do not have to wait for their next routine planned inspection that councils carry out anyway as part of their official control programme. Within our statutory proposals, we can propose that we would obviously continue with these safeguards. However, in response to some of the comments received from the consultation that I just want to briefly take you through so you're aware of those, we have made a number of changes to the original proposals. And the first is in relation to the appeals safeguard. As the scheme operates currently, food businesses have 14 days to appeal their rating. And within the proposals for a statutory scheme, we are increasing this to 21 days. And this is really to enable businesses, particularly the bigger businesses that have central offices, perhaps even located in another country, enough time to determine if they wish to make an appeal. And equally, the time for district councils to determine an appeal has also increased from 7 to 21 days. Just to mention, the scheme in Wales is now statutory. Their Act came into force in November last year. The appeal times we're proposing are in keeping with the Welsh scheme, and we think that's quite important because it gives consistency for businesses that operate across different countries, and it means within a statutory scheme at least they are operating to the same sort of time periods. Just one other thing to say about the appeals. Again, in response to the consultation, a number of respondents queried whether there was sufficient independence because the appeals made to the council that provided that, albeit it's not the same officer who actually would determine the appeal. And following discussions with stakeholders, it has been agreed that the Food Standards Agency should review how the appeals process is operating within a statutory scheme after a period of time to see if any changes would be needed, particularly around the aspect of independence. And just to flag with you that this flexibility also exists currently within the Welsh scheme. Just briefly to mention the re-rating inspection safeguard, a number of issues were raised in the consultation there also. In the current voluntary scheme, a food business can only request one re-rating inspection when they receive their rating, and the council will do that free of charge. However, where businesses would be required to display, we estimate that the number of requests for these re-rating inspections will increase, and when we consulted, we proposed that businesses would pay for these inspections when they requested them, and most stakeholders felt that this was reasonable. We went further then and asked the question, if businesses are paying for the re-rating inspections, should they be able to request more than one? And more than half of the respondents thought that they should be able to do this. This was very much in keeping with the aim of the scheme, which is to encourage compliance and self-regulation within business. There has been concern, however, among enforcement stakeholders that this has the potential to direct their resources away from the poorer performing businesses. We do accept this concern, and enforcement stakeholders view that a limit might need to be placed on the number of the re-rating inspections a business could ask for. However, we don't have evidence at this time to determine what would be reasonable if we were to impose a limit. So again, what we've proposed is that we would again review this aspect of the scheme and its statutory, gather the evidence, and then on the basis of that make a determination if a limit needs to be imposed. Last thing just to say on the re-rating inspection issue is within the current scheme there is a 3-month standstill period after the initial inspection when a business can't receive a re-rating inspection. However, they can then get the re-rating inspection within a further 3 months. We had proposed that, obviously, as we put out our proposals for a statutory scheme, and the response to the consultation from industry was that this 6 months period, which what it could effectively be, was really too long for them to wait to get their rating reassessed. And on review, we agree that since food businesses will pay for the cost of the re-inspection, and as they will now be required to display their rating, where previously they can just choose not to put it up, re-rating inspections should be completed within just 3 months. This has met with severely strong opposition from enforcement stakeholders who don't agree with the loss of the 3-month standstill period, but we do feel it's fair for businesses where they have made improvements and they would have to demonstrate that before they could get the re-inspection. So just one final thing from me, I'll be very glad to hear. One thing that was raised in the consultation was from enforcement stakeholders, and they highlighted the undesirability of them introducing a statutory scheme at the same time as them bringing about the transitional arrangements within the local government reform programme. And we do understand this will be a time of significant resource for them, and we've committed to liaise with all stakeholders when we actually come to agree a coming into operation date for a statutory scheme in Northern Ireland. Just finally, I would like to say that in reaching our final position, which is laid out in the paper to you in Annex 2, we have listened to stakeholders and we have attempted to balance some very diverging views to reach what we think is a fair, reasonable and balanced position. And obviously members will get a full opportunity during scrutiny to invite all those stakeholders before you to hear their views also in our final proposals, and we would urge you to do that. Thank you.
Okay, thank you both for that. I suppose just by way of observation, first of all, I suppose the ultimate objective here is to reduce the amount of foodborne diseases, and it probably is quite a stark statistic when you look at it. The 48,500 cases annually, and your report indicates that's 450 hospitalisations. Costing 83 million to the economy and 20 deaths. So it's quite a stark statistic, which would suggest the need for proaction and action in and around it. And I know that you noted that Wales have now the statutory process in place, but I'm wondering, have you looked at any other examples or models of where the impact it's worked? And I'm taking on board what you're saying about the appeals process and the role that you will have and the flexibility that will be there to review how that's working. But I suppose specifically other models and impact, and then I suppose just a practical question I would have then is when is it likely to come before the Assembly?
Okay, if I pick up maybe your first point in terms of the models, we have been working on this for what seems like years and years, and in the final decision on the food hygiene rating scheme that we put in place in the UK, we looked across the world at all sorts of different models that work in different countries or partly work in different countries, and the decision to go with the food hygiene rating scheme as it sits on a voluntary basis at this minute in time was taken in a very considered way. and we actually made sure that all of the countries of the UK were on board with it before we put it in place, and it works across the UK. The problem that we have now with the voluntary scheme, obviously, is that people don't have to display their rating. Now, there's no appetite at all in Westminster to introduce compulsory display of the rating in England. We believe, Wales obviously believes, Northern Ireland, the Food Standards Agency in Northern Ireland believes that it is in consumers' interests to have that display mandatory. And in Scotland, they're sitting back and considering and watching what has happened in Wales and Northern Ireland, and obviously they will make their own decisions.
What about the Assembly timeline?
For the bill coming before the Assembly. The bill's being drafted currently. We have received a first draft of the bill and are working closely with the Office of Legislative Counsel in responding and commenting to that. I think we could have a bill introduced to the Assembly before the summer recess.
Okay, thank you. There's a number of people that indicated. Sam first.
I have about 5 questions for you, and you have touched on some of them, but you can elaborate more on these. Thank you for your presentation. Number 1, will the measure cover businesses which supply food, and other materials to restaurants as well as the restaurants themselves?
Okay, I'll answer that one initially. The scope of the scheme as it currently stands, and as we have also put forward in terms of proposals for a statutory scheme, is at this point in time to only apply to businesses that supply food directly to consumers. So where you get business-to-business trade, the scheme will not apply in those instances. It's just, at this stage, information for consumers to make decisions.
But we are looking separately, as the Food Standards Agency, at bringing in a similar scheme that would expand it to provide information where you are a customer of a supplier. So those catering suppliers would have to provide certain information to their customers, which would be the food business. That's a separate, yeah.
What penalties are there for failure to display your food hygiene rating?
Okay. The penalty is, yes, as you mentioned, it's failure to supply a valid rating, i.e. a rating that isn't a true rating or not displaying it at all. And penalties would be fixed penalty notices in the first instance with typical fees, I think around £150 to £200. But for situations where persons perhaps continue not to display or continue to display misleading information, then ultimately there's a level 3 conviction. So they're not large fines.
Do you process this through the court or what way?
The fixed penalty notices obviously won't go through the court because the District Council will serve those. It's only if it would go to court, and we wouldn't imagine that there would be many instances of that.
Hope not.
Hope not.
Right. What right of appeal do restaurants have against their food hygiene rating?
Okay. As I mentioned there, anybody who receives a rating has a right to appeal that where they dispute it. And they can do that, we're proposing, within 21 days. So they'll make a request for an appeal. The appeal will be heard within the council. However, it has to be by an officer who was not involved in determining the rating. So a more senior officer, for example, a principal officer or a manager of the food service. And they would make and determine the appeal.
Okay. Are all takeaways in supermarkets covered by the bill?
Yes. Yes, where they supply food directly to consumers, yes.
Okay. Are there any eating places not covered by the bill?
The only places that we will have some exemptions for would be where maybe a business might not typically see it as a food business. So, for example, somewhere like a National Trust shop that sells, many sort of craft goods and a tin of biscuits, we don't imagine that sort of business will come within scope of the scheme because we don't think the consumer will really sees that typically as a food business. The other main exemption is for childminders, and there's also sort of sensitivities around that for child protection reasons. And as well as displaying the rating, there is the website, the public website, and so we don't want to be putting private addresses for childminders on that, so they aren't covered.
Okay. Lastly, you'll be pleased. To what extent are we just simply copying the Welsh bill?
I would say quite a lot, because the scheme has operated before. It's very similar, and we want it to be similar. We think it's better to have consistency for businesses and consumers, so that one rating means the same in Cardiff as it does in Belfast, and the same system backs it up. So a business has the same amount of time to appeal, and if you operate as a multi-chain, you understand how a statutory scheme would work. That's not to say they have to be identical, they don't, but they are based on the voluntary scheme, which has been running for 3 years, and all the framework to establish a fair scheme has been worked out with stakeholders prior to the bill which requires the mandatory display. So there will be a lot of similarities.
And that is actually one of the biggest criticisms that the Food Standards Agency gets across the board is about consistency and consistency of enforcement. So what we're trying to do here is to try and reinforce that consistency of enforcement.
Good. Welcome that.
Quite shocking to see that there are 48,500 cases a year involving 450 hospitalisations. So we're talking about something here that may sound to be quite a sort of an academic exercise, but actually a very serious issue. I have to say, since this has come in, and maybe you can see by my waistline, I'm a very frequent user of takeaways in restaurants, particularly their vegetarian foods a bit good. I have to say, in all of my time, and since I last heard from you, you always instinctively look for the label. I have never seen a 0 or a 1 in a window in my life. So I'm even surprised you got the 13%.
Yes,
Where are these people? I mean, because I just do they actually exist? Is that what they're saying, or is that your check?
No, we
Our
know.
check.
Yeah,
We
know.
have mystery shoppers that carry out audits.
And you're saying to me there are people who will put a 0 or a 1 in the front window of their establishment or on the door?
They
Right.
possibly don't understand.
What they're doing.
that's
Right. Well, that's quite shocking. Now, you're saying that it's going to be a fixed penalty. Now, my concern about that is that surely that's done behind closed doors. That's done in secret. So therefore, if someone refuses, it's obviously going to be the 0s and the 1s, because I have to say, I suspect that every 5 in Northern Ireland, some are prominently displayed. We're a 5 here, by the way, at this moment.
Yes, that's all that, yeah.
I'm glad to say. But then surely, I mean, the reality is that all the 5s will display in glowing colours. Yes, I'm a 5, even the 4s. But if the 0s and the 1s, for very obvious reasons, refuse to display, all that's going to happen to them is that privately they're going to be fined a small amount by the District Council. How are the public any more reassured by that process?
They still have to display. So they have to pay their penalty, but they still have to display, and they can't display leading information. So, if it is persistent, then it will generate a prosecution through a magistrate's court, and that will be publicised. So this is about sorting out, I suppose, the people who are chancing their arms in a way,
Yes.
at first-time offenders from the persistent.
But if I was the owner of Jim's Chippy in
Yes.
Kilkeel,
Yes.
and I get a 0 or a 1, surely this process incentivises me, A, to demand appeals and re-registration, to get a fixed penalty and continue for over a year still serving substandard chips?
No, you won't be able to do that.
I think you've raised an interesting point there, though, and that's about the business continuing to not comply. And the food hygiene rating is there to let the consumer know how the business did it at an inspection at a time. However, if a business is, for example, a 0, there will be issues there that need addressed quite urgently, and the District Council will be using other enforcement methods to put that right. That could range from serving hygiene improvement notices, which give them a set period of time to put the issues right. In the worst-case scenario, they could serve a hygiene emergency prohibition notice and actually close the business down, which obviously would get a lot of publicity.
Yeah.
So
You would have to ask why someone who's getting a 0 or a 1 is actually serving food in the first place.
yeah.
And you'd think that would automatically trigger further investigation by the Council. But even, you said it's a tier 3 fine. Surely, if it's a large food establishment, it would actually almost pay them just to continue to ignore the sanctions, because the reality is that prominently displayed on your front door is probably a kiss of death to your establishment. So therefore, is it even a one-off fine of even £1,000? Does that actually stop that lack of transparency? Does not stop it just continuing?
Yeah. I mean, I think as well, with the statutory scheme where a business is not displaying a rating, and I would imagine that public will contact their councils and say this business isn't displaying a rating, why? and they'll maybe be told, well, it's a zero. We are taking enforcement action against them at the minute because they're not displaying. The fact that they're not displaying also, I think, will have a detrimental effect because people will question why there's no display when they're required to do so.
We have had an awful lot of interest as well from the media in relation to the food hygiene rating scheme. So the local papers are well tuned into this and they are picking up on per performance from takeaways. So it's all incentivising really, and what we're trying to do is move the norm, shift the compliance, and actually most businesses are very, very good. We have to say that, you know, in Northern Ireland most businesses are either 3 to 5. It's not, you know, it's not the norm to have a 0 or a 1.
But going back to Jim's chip shop in Kilkeelan, if I was running it, I would certainly get a 0 or a 1. I have no skill or knowledge in this field at all. Now, say I decide to bag up to Nuts Corner and get myself a counterfeit sticker saying a 5, and I stick it up, what is the likelihood of me being caught? And is that also a fixed penalty?
I mean, the fixed penalty notice is discretionary whether the council use it or not. They may decide that is significantly serious. You are wilfully misleading the consumer, and in the consultation, people come back and said they see that as much more significant. I could see that situation you've described perhaps going straight to court.
Well, that's good, because in a small rural community, that is the greatest deterrent, is it appearing in the local press that Jim is useless at running a chip shop and his hygiene standards are very low. And I'm glad there's that option, rather than having a series of fixed penalties, which really don't count as a deterrent at all because the public don't know.
And I think as well, we can't underestimate the work that the district councils do, the environmental health officers who are on the ground, who are out in Kilkeel every day of the week, checking these businesses, even just walking up and down past. They know an awful lot. They have a lot of intelligence, and I'm sure you're well aware of the work that they do. So it would not go unnoticed, Jim, in your cafe, and I think you would be hauled over the coals quite quickly.
Good to hear. Good to hear. Thank you.
Yeah, thanks for the presentation. I suppose it's more of an observation because it's all about consumer protection. I mean, in one of our streets, there's about probably 20 food outlets. Some of them large, some of them small, some of them open and close fairly regularly. And I would have thought it's such a competitive business that everybody would be striving to get the highest rating. You know, and obviously some of them are side by side, so if one has a 5 and one has a 3, presumably people can make that choice. You know, but it just seems it's such a, you know, simplistic thing in a sense, because you'd assume that if you open a business that deals with food, then you'd be going for the best standards that are possible. You know, so, you know, I'm not sure if there's special dispensation for vegetarian outlets. I presume there's not.
Of course, there are no hygiene problems because it's so healthy.
Or otherwise, but you know, you just feel that there's so many food outlets now, and it's such a competitive business that really, this is one way of gauging, you know, how good or how bad in a sense they are, and you'd assume that people would strive for the best possible mark in a sense.
Well, I think, you know, I live in a small town myself, and there are four takeaways.
Small town, we're a city now.
Yes, that's right. But 4 takeaways, 3 have 5. 3 of them have 5s, a rating of 5, and the other one doesn't. The other one is not displaying. So myself as a customer I can't make a decision about that at this minute in time, and that's why we feel that this legislation is vital.
Thank you. No, that's it.
Again, thank you for your presentation. I think it's a very good scheme to date. There's a positive incentive for those who wish to display it, but as of yet, the stick has not been there. But to determine whether or not that stick is needed, can you perhaps delve a little bit more into the numbers for us? You've indicated there's 48,500 cases annually of foodborne illnesses, 450 hospitalisations and 20 deaths in Northern Ireland, costing the economy £83 million a year. What percentage of all of that is coming from the home as opposed to commercial businesses? Because this will be another burden of business. I'd just like to satisfy myself that it is needed to go compulsory.
Part of our difficulty with food poisoning statistics is that there is a massive amount of underreporting. So we think that we probably only pick up about 10% of the true numbers of people who suffer food poisoning, and that's for a variety of reasons. Some people don't go to their doctor, some people do go to their doctor but don't get the proper samples taken to prove that they have had food poisoning. So it is actually very, very difficult for us, Roy, to answer your question. We know that a lot of food poisoning still does occur in the home. There's no doubt about that, and we try to reach consumers in other ways to explain and give those messages to them on an ongoing basis. But you know, I came and talked to you this time last year about the second largest E. coli outbreak in the UK in one of our restaurants, and those statistics alone really bump up the figures. So if you have even one, it's too many. One is too many.
Well, are you concerned with the current voluntary system that those who are not getting good results can just hide and just, you know, that they may not be improving as fast as they should be, and continuing to offer a service with a degree of risk to the public?
We're satisfied that the district councils have put in place a coordinated effort to try to bring those businesses that are rated 0 to 2 up, so to increase their scores. We're more than satisfied with the work that the councils are doing, but that isn't visible to consumers, and that's the problem. So consumers are still purchasing from those businesses quite happily, and we just want to give people the choice. If you're going to eat from your favourite takeaway, you're going to eat from your favourite takeaway. Now, this may influence you, it may not, but give people the information that they need to make informed choices.
What additional cost, if any, do you see falling on the ratepayers and going to compulsory status?
Yeah, in terms of cost, this scheme really sits on the back of the official control programme that all the district councils are obliged to carry out anyway under EU requirements. They have a system of official controls inspections. They carry them out routinely in their areas. They do those, and they have to do those. And it's only once they do those that they use the evidence that they gather to generate the rating. So it's just the final bit on what's already done. We don't really see there being a big cost, because all we're asking the business to do is to display their rating. We accept some businesses won't get a good rating. That means they're not complying with the basic legal requirements. So they're not doing what's already established that they should do in terms of all member states are being asked to do the same thing. So it's really just, as we say, to pass the information on, and so we don't see large costs for that reason.
Just a final comment. There was discussion earlier on about whether or not business should be allowed to make improvements and get a retest quicker than normal. I certainly would want to be very supportive of that, because it should be about bringing about improvement rather than closing businesses. And if businesses want to bring about significant improvement, sure, that's great. And therefore we should not stand in the way of them bringing about the improvement and being able to show a better performance.
I think that if you bring the district councils to speak to you about this issue, they're very, very nervous. They're very nervous about the extra resources that would be required to put in the effort on the re-inspection visits and to reassess the businesses. So you will hear that. We have to put that in front of you, because that's what we have heard from the councils.
But would that not be paid for and given additional resources to the councils, been paid for by the business who wishes to speed up the assessment?
I think that's why we have built this scheme in the way that we have.
Okay.
Thanks very much, and apologies. I was out talking to some students there, and that's why I had to go out. Yeah, I remember the last time I think you were here, we were talking about the horse meat issues, and certainly we were made aware of the limited resources that the environmental health departments within councils have, and I know as local MLAs we give them quite a bit of work as well. There are a lot of issues out there in relation to noise and dampened properties and so on. So there is a terrific workload placed upon these environmental health officers. And, under RPA, I would ask, will they have the necessary resources allocated to them to carry out the business? Because it is more and more increasing in demand, and I cannot understand that. As a former councillor just a few months ago, the officers are really under a heavy workload. Just in relation to the assessments and the audits they carry out, I take it as a risk-based assessment. And they carry out surveillance, as has been mentioned earlier. Surveillance is all about awareness and knowing what's going on out in the street, just basically. And so how are they going to manage under RPA? Will there be adequate resources in place, or do you feel that a greater effort needs to be made and perhaps more of an emphasis in relation to public health within councils?
Catherine and I both come from a district council background, as you know, Gordon.
Yes.
We have worked in the councils for years ourselves, so we understand the pressures that they're under, and we are very worried about this as the Food Standards Agency, and we have attempted to discuss this with the Chief Environmental Health Officers Group and other groups of council leaders. I think they're in a bit of a hiatus at the moment because they're not really making any decisions before the new chief executives are put in post, which is correct and right. So I think, you know, there is going to be a period of very intense discussions with the councils in the lead up to the transition and beyond, just to make sure that they retain the resources that they currently have to do the job that they need to do, and that's what we want. We want to make the service very strong and help to put the resources into the service, because we provide them with some money as well. So in terms of the food service, we want to make sure that it's strong and robust for the future.
There's work to be done, you reckon?
There is. There is, definitely.
I always remember the horse meat issue, the frozen horse meat that came in. No one really had taken samples of the meat because obviously resources were limited. It is quite a complex operation. A lot of the meat, as I understand, came in frozen bulk. It was like a commodity moved around and no one really seen it or witnessed it. So, you know, those issues, it takes resources to manage all that. I think
and that's a whole other committee discussion, I think. We would love to come back to the committee and talk to you about the work that we have been doing over the past year on, you know, in the legacy of horse meat, and also then all the reviews on the horse meat incident. So we'll come and present to you on that soon.
Great, thanks very much. Thanks, Chair.
For just reminding me as well, probably just given local council's role in all of this, it's probably appropriate for current councillors to maybe declare an interest. I'm not sure who is or who hasn't, but I think it for the record. All right, good. We do have progress. Okay, okay. So thank you very much for that presentation. It's useful information for us. Thank you, and it's been very detailed. Thank you. Members, moving on to item 6 is a statutory rule, which is the deregulation, improvement of enforcement procedures, food safety. It's on page 32. We did consider and approve the SL1 for this rule at our meeting on the 6th of November 2013. So just asking, are members content with the statutory rule? And if so, saying the Committee for Health, Social Services and Public Safety has considered the deregulation order and have no objection to the rule, subject to the report of the Examiner of Statutory Rules. Item 7 is another statutory rule, is the infant formula and follow-on formula regulations, page 38 of your papers. Again, we had considered this SL1 for the rule on the 13th of November 2013. I'm asking, are members content?
Great.
And putting the motion that the Committee for Health, Social Services and Public Safety has considered the infant formula and follow-on formula regulations and has no objection to the rules, subject to the report of the Examiner of Statutory Rules. Item 8 is the Forward Work Programme. I'm asking members to note the Forward Work Programme on page 44, advising members again that the Minister will be present at the committee next week to discuss the A&E issues and the budgetary pressures, as we requested last week. Item 9 are matters arising. Item 9.1 on page 49 is a response from the Minister providing an update on the programme for government delivery plans as of the 31st of December 2013. Members had indicated that this is an important tool for the committee in relation to our scrutiny rule. I'm suggesting, however, that the committee schedules a briefing at the next quarterly update of the plans, which will be in and around the 30th of April 2014, and the committee could therefore be briefed in May in relation to this particular issue. So If members are in agreement, we can proceed on that basis. And taken by your silence that that's agreement. Okay. Item 9.2 on page 117 is a response from the Minister to the Public Accounts Committee regarding the report into the fire service. And the Minister has provided an investigation report done by the fire service into charity vehicles. Further correspondence on the issue is at page 9 of the tabled papers today, and it's from the Chair of the PAC. The PAC has decided to send the Fire Service investigation report to the CNAG for further assessment. So, in the meantime, are members content to note?
Right.
Okay, thank you. Items 9.3 on page 128 is a response from the Minister regarding work being done to improve emergency departments. We have noted through Chairperson's business that there is the tabled letter today announcing the review into the RVH, and we have requested that we get the terms of reference and what he's referred to as, the Minister's referred to as an expert team, external expert team, that we seek that update during our meeting next week with the Minister. Are members content to note that in the short term? Okay, thank you. Under correspondence, item 10, I'm asking members to note 10.1 and 10.5. Sorry, did I?
Yeah, just this.
Oh, 9.4, sorry, I jumped ahead of myself. 9.4, it's just the Minister will be briefing the committee on this particular issue at the next meeting. So I'm asking our members content to note that in the meantime. Okay. Correspondence is item 10.1 to 10.5 on pages 130 to 169. Item 10.6 on page 175 is a letter from the Causeway Hospital campaign seeking a meeting with the committee. Given that they wish to discuss the future of the local hospital, again, we're suggesting our normal procedure that they contact constituency representatives for further support and assistance. Members agreed. Advising members that the stakeholder event with the groups has been arranged for Wednesday, the 2nd of April, from 2 p.m. to 4 p.m. in the Long Gallery. Item 10.7 on page 176 is a letter from the Centre for Health and Wellbeing asking if they could attend the event on the 2nd of April. I don't see any reason why members wouldn't be content to invite them along. Okay, thank you.
What's the format of that again, Chair?
Do you want to brief? It's a 15-minute slot paragraph, but Catherine will have more detail.
Yes, Chair. It's going to run between 2 p.m. and 4 p.m. And it'll be 15 minutes per group, and ideally with three tables of members, so that could accommodate 24 groups to be seen within that period.
And that'll be on Wednesday, 2nd.
The 2nd.
Yeah.
Okay.
Thank you.
Okay, page 19, item 10.8 of the tabled papers is correspondence relating to Ms McCoy, who is asking to attend the event. We're noting that in August 2013 the committee received correspondence from John McAllister, MLA, requesting a meeting with the Health Committee on behalf of Ms McCoy. She's concerned about her brother's health provision. Ms McCoy should seek support from constituency representatives, and it is important, members, that we maintain this line. I'm suggesting that we write again to Ms McCoy to suggest that she contacts the constituency representatives and the Patient Client Council for support in this case. Are members in agreement? Okay, thank you, thank you. Item 11 is any other business. Do members have any other business? Item 12 is the date and time of next meeting, which is on Wednesday, the 12th of February, starting at 2 p.m. in the Senate chamber. Thank you.